Go live.
Good afternoon, doctors. I, Dr. Prashant, welcome you on behalf of HETRO to this webinar on influenza and its prevention. We have got two eminent speakers today, Dr. Ketan Shah and Dr. Ravindra Chopra. Dr. Ravindra Chopra is MBBS MD Pediatrics, Chief Pediatrician and Director, Muskan Children Hospital, Surat. Dr. Ketan Shah, MD DCH, President, Surat Pediatric Association, National Trainer for ATM, PSPP, ASK, IAP, CPIDC, How Do I Investigate, Rational Antibiotic Practice, National TB Module, RAPID Module. Sir has been National Secretary, Pediatric Rheumatology Chapter, Organizing Chairperson, National Rheumatology Meet, EC Member, Gujarat Pediatric Association, 2014 and 19, EC Member, ID Chapter, 2000. Welcome both of you on behalf of HITRO. I welcome both of you. HITRO Healthcare, as you all know, is an innovative pharmaceutical company. Our journey began in 1993, and we have got about 30 plus years of excellence, 300 plus products in a portfolio, 20,000 employees globally. We have got state-of-art manufacturing facilities, presence in 126 plus countries, and we have got Asia's largest manufacturing complex at Visakhapatnam. We provide 360 degree solutions, striving to fulfill unmet healthcare needs. We reach out to customers across India, and we have got a wide product range encompassing multiple specialties like respiratory, dermatology, pediatrics, infectious diseases. We pioneer in quality and innovation, and we have got distinction of bringing 4 biosimilar products to market within 5 years of launch. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, we have introduced antivirals like favipiravir, remdesivir, and oseltamivir. We have received award of Pharma Excellence in August 20 for COVID drugs. That's all I want to say. Over to you, Dr. Ketan Shah, for your session.
Thank you, Dr. Prashant sir, Dr. Ravi. Very good afternoon and happy Diwali to everybody. Samruddhi ji, she has been in touch with us for all through last week. Now we'll have some discussion about flu virus or oseltamivir, its use and what is going on in India or in Surat city. That's what we are going to discuss. Dr. Ravi has been very knowledgeable, very expert person so far. So all respiratory diseases are concerned. We'll have some bi-directional talk. I'll be talking somewhere. Dr. Ravi would give input into that. We'll have a question answer, and both of us would be discussing the topic. See, we'll be discussing about healthcare challenges in monsoon and their diagnosis. Influenza and its complication, the clinical evidence of oseltamivir, so far so literature and so far so clinical practice is concerned, and the empirical use of oseltamivir in case of a flu season. The healthcare related challenges are in the monsoon in the form of influenza-like illness, ILI, H1N1, we all know, severe acute respiratory illness, SARS, COVID, and maybe ARDS or significant involvement of the lungs. This has been a day-to-day practice in this season. Let's have some discussion. Dr. Ravi, what we know about influenza in India? Can you highlight something? How much prevalence is of influenza in India, and which season, and which is the correct time to vaccinate? Dr. Ravi, over to you.
Thank you, Dr. Ketan, for nice words of introduction. Thank you, Hetero Healthcare, for giving me this opportunity to speak on this very interesting topic. So, if you talk about influenza, first we have to know what is influenza-like illness, because it is a subcategory of influenza is a subcategory of ILI. So any illness which is acute respiratory infection which presents with fever, which is more than 100.4, along with signs and symptoms of acute respiratory infection like sore throat, coughing and cold, stuffy nose, myalgia, body ache, sometimes cough pain. So this is a broad category of ILI. And I would say for our pediatrician friends, this is bread and butter of our practice. So if we see such kind of ILI cases, probably out of all ARI cases, around 1/10 are probably influenza cases, either confirmed or not confirmed in our day-to-day practice. In India, we lack a lot of data because reporting is always under-reporting. Global burden of the disease is around, it is said that probably we have a 1 billion cases of influenza every year and lot many deaths. So with the reporting system placed with the government of India, we have few data. And so for example, in this year, in year 2024, probably around 14,000 cases of influenza has been reported, and out of which mortality is around 335. And in Gujarat itself, there has been 33 deaths reported because of influenza. If you talk about our part of the country, like southern hemisphere, main season for influenza is post-monsoon season. Generally starts from probably August to October, and there is another peak which is winter flu. Winter flu is generally seen from January to March. Though we lack seasonality of influenza in our country as compared to the Western world, and there are sporadic cases all around the year, but these two distinct peaks are there. Hence, our vaccination is planned in such a way that we cover these peaks. So, in our part of India, we prefer generally the southern hemisphere kind of a peak or southern SH strain of influenza virus. And the best time to vaccinate is pre-monsoon, because as we know that there is some lag period between the acquisition of immunity and administration of vaccine. It is always better to be prepared beforehand. So before the peak arrives, we generally start vaccinating in the month of April. And the second peak, like in the northern hemisphere, the vaccine is ready by around August, and they can start vaccinating in this month, August to September, so that they cover a winter peak. Over to you, Dr. Ketan.
Yeah, very nicely elaborated, Dr. Ravi. And we have a huge data, scientific data, favoring whatever Dr. Ravi has told. Flu does exist in India. We do get lot of cases, January to March, and in the monsoon season, OPD is flooded with the uh, influenza cases. So we have some photograph or pictures or the graph chart. This graph chart is from Indian Academy of Pediatrics vaccination book, which is called as a Purple Book, which was published in 22. And this is from page number 324. It is showing a peak between January to April, some lag in May, June, and again July, October. So two peak in between quiescent phase, and again you get a peak. Sometimes it happens that July to October peak may increase, Jan to April may little bit go down also. But the huge burden of the disease, these are the data showing a number of respiratory infection, 13 lakh 96,000, 13 crore 96600 is a total respiratory infection. And per 1,000 you get 1,000, per 1 lakh you get 1,000 cases, hospitalization 42, and death is around 1.8 per 1 lakh. This is a global burden of respiratory and influenza infection. These are the year-wise cases statistics. Again, from the Purple Book, I had taken a photo. In 2022, 12,800 cases were there. That is up to November 22 and 399 days. This includes pediatric as well as adult also. Indian data, 5 to 10% of all ARI are due to influenza. 10 out of 100 child per year suffer from influenza. There are different studies from India quoting that 178 to 180 per 1,000 children per year below 1 to 2 years are influenza disease. Influenza associated ARI is 33 to 44 per 1,000 per year. And we all have faced the classical pandemic of swine flu in 2009, 2015 also, where up to March only 30,000 cases were detected up to March and 1,800 deaths were reported. So a two very big pandemic of influenza India has faced, and probably these year also we are facing a huge challenge. Dr. Ravi's OPD of around 80 to 90 might be 15-20 are influenza. So these are the data, and Dr. Ravi has rightly said Northern India, the peak is in Jan to March, Central India, July to September, Southern India, September to November. But this can be variable. So throughout the year, India would have the influenza disease. Dr. Ravi, would you like to highlight this slide?
Yeah. So if you see this slide, that influenza, the incidence of influenza and related death, they are increasing alarmingly. So we can see in this slide that these are the cases from beginning of 2015 to 2019. We can see the 4,200 cases. Then the next year it was 15,000, and now the latest they had was 28,700. So there are in between, like it is a kind of a, I would say, influenza is a kind of a periodic illness. So in between there are genetic mutations in the virus, and we have epidemic or pandemic also. So there will be something like in 2009 and 10, there was a pandemic of swine flu, and we had a lot of cases. So, but overall, if you see, there are two things basically. One, that we become more aware of influenza. We have started reporting more and more cases. We have more knowledge of influenza. And second thing, the influenza burden is also increasing. So if you see the deaths also, the deaths are also consistently showing a increase. In this slide, we can see as compared to 299 deaths in 2015, the number of deaths had risen to 1,218 in 2019. So that speaks about the increase of the disease burden.
Thank you, Dr. Ravi. And this is one more study which has been done in the Chennai. Dr. Ravi, would you like to highlight on this slide?
So basically, this depicts the dynamics of occurrence of influenza. This is a 7-year cumulative study and done by Department of Virology in 2019. So there were 36,670 specimens which were studied for influenza analysis. And this study was conducted over a period of 7 years. Uh, yeah.
Sorry, I'm sorry. Please go ahead, dear. Sorry.
Yeah. So in this study, it was depicted that influenza positivity generally started with the onset of monsoon season, and it peaked during the post-monsoon month, which also corroborates with our finding. Like we are still getting a lot of cases of influenza this time. Next slide, please.
See, this is basics about
Okay.
influenza. Dr.
Yes.
Ravi, please go ahead. Please go ahead.
So as we are discussing again and again, influenza is one of the most common infectious disease caused by influenza virus. So influenza virus is a virus from Paramyxoviridae family, and it is having four subtypes A, B, and C, as well as D. D does not cause disease in human, so it is a basically virus restricted to cattle only. A, B, and C are of importance, and foremost importance is of A and B. So it is a highly contagious airborne disease. one of the most contagious infection to occur in humans, and it occurs in seasonal epidemics. Like for example, pandemic. We had a Spanish flu pandemic in 1917 and 18. Then we had recently had a pandemic of swine flu in 2009 and 10. So this can occur in the pandemic, epidemic. There may be sporadic cases, and there is a little bit of endemicity of this virus also. And it has a varied presentation. It has a clinically varied presentation, starting from a very mild respiratory infection to very severe and critical illness, especially in patients who have a comorbid condition. Then it is one of the very common cause of hospitalization, and in high risk group there is high chance of mortality. So as we discussed, there are three kinds of influenza virus. So influenza A virus is one of the most virulent virus. It causes frequent epidemics. Uh, we will first discuss about drift and shift.
Yes.
When we talk about influenza virus, so the most important why we don't develop immunity to this influenza virus, why we have to take vaccination every year, and even then we suffer from influenza. Many of them suffer from influenza in spite of taking vaccination. So we have to know this basic fact that this virus is a ever changing virus. So there are kind of two kind of mutation. One mutation is a kind of a drift mutation, small genetic mutations within the composition of virus. So they bring about the seasonality of virus, seasonal changes, or generally seasonal flu. Every time we see in our vaccination leaflet that this time vaccine virus is blah blah blah, and next time it will be different virus. So these are basically drift mutation, because the previous virus does not, the previous virus, previous immunization or previous infection does not impart immunity for the mutated virus. Hence, we have to take vaccination. Second is a shift. This is a kind of a whole new virus. So this is a basically change in the genetic framework of the virus. The whole virus is behaving as a new virus. And these viruses are dangerous viruses because human being does not have even minimal immunity to them, and they spread like anything. So the one of the biggest example of kind of a pandemic was Spanish flu in 2000, in 1972, 18, when probably it is said that one third of Earth population was vanished. So that was a kind of impact this kind of a virus will have. Similarly, with better knowledge, we have good drugs and many procedures in place, so that this kind of epidemic we can limit them, or we can minimize the damage. That we did it with swine flu in 2009 and 10. So this is basically a shifting mutation. So most commonly this kind of a mutation happen with the virus, influenza virus A. B virus also have some kind of mutation, and it can cause epidemic, but more or less it is quite stable virus. And there are two subtypes of this B, Victoria and Yamagata strains. So these are the fixed virus. There are minor mutations which happens with this virus. Influenza C virus is a kind of a milder virus which sometimes infects human. Basically, it can infect swine also, and it does cause a mild respiratory illness. So our vaccine is mainly targeted for influenza A and B, and our whole of the clinical scenario is probably focused more on influenza A virus. Over to you, Dr. Ketan.
Thank you, Dr. Ravi. I think you have done PhD in flu virus, isn't it? Knowing A, B, C, shift, drift, PDM, Brisbane, Yamagata. So this knowledge is really very important for a practitioner.
Really
Patient
amazing, huh?
comes,
Really amazing.
patient comes and asks you that, sir, last year you had given a vaccine. Why you want to take it every year? So it is important to know what is a drift, shift, and
Right.
shift is really a worrisome. It causes major pandemic, and we don't know which shift has occurred, either in neuroaminidases or hemagglutinin antigen or not. And even we write down PDM09, that is depending upon the bulk variation. So every vaccine would have a long name, A, H1N1, Brisbane strain, etc., etc. Thank you, Dr. Ravi, for a very nice elaboration. And as you had already discussed that it is a highly contagious virus, this slide shows that it can spread very fast. So we are also supposed to wear a mask. Don't put your hand in the nose, eyes, and mouth. When we get the infection, we have to do a hand washing. So for healthcare person also, it is very important. And once the patient is infected, it can pass on the virus to the whole community. Once the patient is going to school, they are the really a transmitter for the whole school also. This is something about Dr. Ravi. Would you like to highlight some minor difference which you can get it on the clinical presentation about influenza-like illness? I is influenza-like, then H1N1 is influenza, SARI is a severe acute respiratory tract infection in COVID-19. First thing, Dr. Ravi, when a patient comes to you, can you clinically diagnose, is it COVID, is it SARI, or is it H1N1?
Thank you, Dr. K. Actually, it sounds very easy to write in a piece of paper, but it is really not possible, and nobody can claim that he is an expert in this thing. So there are very minor differences, but of course, sometimes there are pointers towards if you take a detailed history and you spend some time in clinical examination, history is more or less more important because the sign, symptom, and the family history actually leads us to diagnosis many a time, rather than just a clinical evaluation of this thing. So one very important thing that I have observed and I have read somewhere also, in this like last 2 to 3 years, for influenza. I may be, biased maybe, but I see influenza cases, the pure influenza, which I have investigated and found out that they are RT-PCR positive influenza. So they generally lack rhinitis. Generally, they don't have that much of cold. Cough is a predominant symptom, which I have noticed over and over again, and I have noted in my clinical observation that these influenza, which I found them, actually I proved them with RT-PCR, all of them they have fever. Fever is the cardinal symptom, but the cough is the main symptom with influenza. And in ILI, if you talk about ILI generally all we include all kind of a viral illnesses in this, which present like influenza. Their main presentation is generally start with rhinitis. So generally cold, nasal discharge. Though it sounds easy, but it is quite difficult. In this slide, it has been elaborated like fever is the cardinal symptom of all the illnesses, whether it is ILI, H1N1, SARI, or COVID-19. COVID-19 probably it has been highlighted maybe a little bit more, maybe out of proportion also. The importance of loss of smell and loss of taste and other systemic symptoms like diarrhea. These are more common in COVID-19, which we have also seen during the COVID-19 pandemic and which are generally less. But sometimes I have noticed even in other viral illnesses also, especially in rhinovirus also, we find the same finding loss of smell and taste, though albeit in a lesser number of patients and probably in less severity. So it's very difficult to say, but yes, of course, strong family history of influenza-like illness in the family. Then the seasonality of infection. So we see post-monsoon flu. So it is very easy to make a diagnosis. Probably it is an influenza. So rest the sign and symptom like fever, myalgia, cough, lack of energy, sore throat. They are almost the same in all the viruses. Breathlessness probably is little early in these H1N1 and COVID-19, and rest of the minor viral infection, it may not take place. So it may or may not be the part of ILI, but most of these like H1N1, SARI, and COVID generally they have lower respiratory involvement. So then as we discussed about loss of smell and taste, diarrhea and headache, these are also quite variable things. So most important is the seasonality, number one, and family history of infection, and the lower respiratory involvement. I would say these are the three cardinal things we think about influenza and other viruses. Over to you.
Thank you, Dr. Ravi. Very nicely elaborated things. See, clinically difficult to diagnose, but lower respiratory involvement, whenever it comes, it may be whatever virus, we have to be alert about it. Myalgia, body pain, they are non-specific symptoms. Dr. Ravi, what would be the spectrum of influenza disease in pediatric practice? We set aside the adult, but starting from 0 to 100, what are the symptomatology, which is the serious sign symptoms? Although I have enumerated, but can you detail it? Over to you.
Yes, sir. So, influenza has a varied presentation. It can start with a very mild upper respiratory infection, which generally can go unnoticed in many of the kids. But in some of the kids who have some comorbid conditions, some immunosuppressive therapy, or a condition, underlying condition like nephrotic syndrome, rheumatological diseases, and especially in a very young infant, especially less than 2 years of age. In literature, it is said to be less than 5 years, but in my practice, I say that less than 2 years generally they have a very severe presentation because generally they present with lower respiratory involvement. Then the other signs are sometime in the younger kids, other than the respiratory finding, highly irritable child. Then there may be refusal to feed, repeated vomiting, and in a little older child, there are few subsets of patients who just complain with fever and myalgia with cough. So extreme myalgia symptoms. Today itself, I got a patient with proven influenza who had a CPK of in thousands. So sometimes these kind of kids presentation does happen. So it is a very varied presentation. But yeah, core will be fever and respiratory symptoms. Over to you.
Thank you, Dr. Ravi. So the symptomatology starts from mild to very serious and at-risk children. And one is a Ray syndrome, which can come up if patient is
Yes.
by mistake taking aspirin. There are chances that child may end up with acute hepatic encephalopathy. And a child who is on aspirin, maybe for rheumatologic disease or Kawasaki, they are also at risk and immunocompromised.
Right.
So we'll have a rapid fire on these background in subsequent slides. These are, Dr. Ravi, I'm just speaking out that these are the warning signs of flu sickness. Any disease which comes with compromised ABCD is at risk. So in respiratory, fast breathing, blue cyanosis, not drinking, grunting sound, not alert, not waking up, or very irritable, cough, cold, SpO2 or a saturation level is low, fever with high rash. These are the really a worrisome sign of any disease. And in respiratory season, this is most likely to be a serious variety of influenza. In adult also, this can come up with respiratory compromise, sometimes cardiac compromise, confusion, CNS involvement. So every clinician is supposed to be alert when these symptoms are there. Dr. Ravi, can you highlight which are the diagnostic tests and do we recommend routinely or in few cases? What is the specificity and sensitivity? Over to you, Dr. Ravi.
Thank you, Doctor. So before we go to diagnostic tests, let me briefly talk about the categorization of influenza. So generally, symptomatically, we divide influenza in three categories: category A, B, and C. A is a kind of a milder illness, just with fever, sore throat, little bit of myalgia, maybe headache, and the routine symptoms with the running nose. And so these kids, they require just a symptomatic treatment. No diagnostic tests are indicated, and you just isolate them. Good home hygiene, and you follow them every 24 to 48 hours with the signs of warning, and then give them good hydration, and just paracetamol and all these things. The second category is category B. So category B is a basically little serious part of category A, in which either the patient is in high risk group, as we already discussed, or patient is having very severe throat pain, sore throat, or high fever ranging above 102. So these all patients will require uh, antiviral therapy, but still diagnostic tests are not required in this category in our country because of probably expensive nature of investigations, as well as non-availability of tests so easily in all peripheral levels. Probably in other countries, Western world, diagnostic tests uh, are indicated in such cases also. The third is a category C. C is a sicker patient. As Dr. Ketan already mentioned, these are the warning signs when we have a child with respiratory compromise and other serious signs and symptoms and requires hospitalization. There comes the role of diagnostic tests. So diagnostic tests are of various types. The gold standard is a viral culture. So viral culture generally takes around 7 days. So probably we get the results even after the recovery of the child. So that is probably not practiced and it is of academic importance only. Second is a rapid influenza test, which is also not readily available in our setup. So that can be a corroborative test. It can give result very fast. Two types of RT-PCR. One is a standardized WHO approved RT-PCR and another is a part of influenza panel in which there is no subcategorization of influenza species. They are also available, which gives results in around 4 hours, 4 to 6 hours, and that can help in managing the child. So the gold standard will remain RT-PCR with a standard WHO or pre-qualified lab where we get a sub-specification of the virus or viral culture. Another important test is a fourfold rise in antibody titers. Basically, this is also more of a epidemic control kind of a test in which we survey the patient to know whether how much population has suffered from influenza. The transportation and this diagnostic carrying out diagnostic tests has a different kind of a guideline that are beyond the scope of this presentation. But of course, there has to be a strict guideline should be followed for that also. And the second point is if you talk about complications of flu. So flu can complicate in many ways in infants and children, especially most common that we find day to day. The first is a pneumonia. So lower respiratory involvement either with the virus per se or with the secondary infection. Then other complications of respiratory illnesses like ARDS, requirement of ventilation. Then upper respiratory complications like otitis media, sinusitis. These are very common in young children. Then other complications can happen with other systems like even myocarditis has been reported in kids. Then CNS involvement in the form of encephalopathy, encephalitis, myopathies in some of the kids. So these are the rare complications. But in children or adults who have already has some kind of a comorbid condition, the most important thing is the worsening of the comorbid condition. Like if a patient is of IDDM, the worsening of IDDM, heart disease, so worsening of that, nephrotic syndrome, any rheumatological condition, the worsening. And then, as Dr. Ketan already mentioned, that some kids they do accidentally take aspirin or are on already on aspirin. Ray's syndrome is a very life-threatening complications. So we need to be aware of these complications while treating flu. Thank you.
Thank you, Dr. Ravi. Just to summarize what you have told is severe acute respiratory infection can have these much complication, which Dr. Ravi has already highlighted. The category A, B, C, Dr. Ravi, we would remember, and in the few slides, we'll have a Kaun Banega Karorpati like questions where you have only 10 seconds to answer A, B, C. Okay. So whenever we discuss the case,
You lost your voice, Dr. Ketan.
is it so? Okay. Uh, just a minute. Now, am I audible? Hello.
Yeah, now you are audible.
Yeah. So we
You are
discussed.
audible.
Yeah, now you are audible, sir.
But
Okay.
I think Dr. Ravi's frame is freeze.
Okay.
Okay, just a second. I'll just see if there is something issue. You continue, Dr.
Yeah, I continue, Dr. Ravi.
Ravi, I think your internet is not stable or something.
I'll continue. Let Dr. Ravi to join.
Yeah.
So these are the
Okay.
complications of severe acute respiratory tract infection. Dr. Ravi has categorized clinical
Yeah, please
presentation.
continue.
Dr. Ravi?
Yes.
Okay, fine. Huh?
Yeah. Yeah.
So just summarize the complication and the classification also. Uh, let's talk about management of influenza. Whenever you see the patient in OPD, Dr. Ravi, these are some guidelines for the management. For primary cases, those who are in category A, it's basically a supportive treatment, paracetamol, cough suppressant if needed, adequate hydration, and no NSAID. That means no aspirin, no
Yes.
naproxen, etc. Mostly they recover within 3 to 5 days, not only three, they may be 3 to 5 days, and malaise may persist for weeks. Severe cases, whenever comes, they need more supportive treatment. Uh, Treatment with antiviral drugs, we have a two category. Neuroaminidase inhibitors, which is the gold standard, available for a longer time and a very good steady drug. Adamantanese drugs, they are basically a channel blockers. They are there, but they are not very good drugs so far, so various experiences are concerned. The oseltamivir, zenamivir, amantadine, and rimonabtadine, these are the four drugs. Majority of the experiences with oseltamivir all over the world. Antiviral therapy with oseltamivir, will little bit focus on that. We have already discussed that in this season, we get so many cases. Very often and very frequent, there are cases of flu. Now, Dr. Ravi, it's like a KBC. You have discussed everything.
Yes. Yes.
Infant 2 weeks, fever, cough, cold, family history of ARI, adult admitted for ARI. Line of action, category A, B, or C.
So
I guess.
basically, this kids automatically comes into category B at least. With the clinical examination, probably maybe a case of probably category C or B at least. And if the child is not sick enough, but still with the age group he is having with family history, probably it is influenza number one, and probably it is B plus category. So along with uh, saline nasal drop, isolation, and all these things, taking care of hydration, everything, we need to start with oseltamivir in this child. 5 days therapy with a close follow-up of this child because they can worsen very fast.
Dr. Ravi, at 2 weeks oseltamivir, does it not cause any side effect? What is the safety profile of oseltamivir at these age?
So at one time there was a time when this drug was not studied in infants and younger kids, but nowadays a lot of studies are still available with even with the use of oseltamivir even in the preterm kids also. But having said that, you have to be very judicious in using. You have to have a strong background of using this drug with monitoring. Uh, I have used in younger kids once or twice, but have not encountered any problem. It is extremely safe drug. But though few side effects has been reported, and we should be careful with that.
What Dr. Ravi has said is very right and true. Oseltamivir does not have any serious life-threatening side effect. So this is the very important safety point. They may have some diarrhea, some cramp in the abdomen. But
Yeah, vomiting, fever.
absolutely a safe drug. There is no harm in starting at 2 weeks of the age, even preterm. It is absolutely safe drug and we should start. This is the high risk category, B category. You should not wait. The cost of investigation is 2 to 3,000 and the molecule cost is around 400 to 500 rupees. So it is more
Right.
safer, cheaper, safer approach. One more KBC, Dr. Ravi. 5 years, walk-in patient, mild fever, myalgia, cold cough, healthy child, no family history of ARI. You have only 5 seconds to answer. Should you start or should you not start?
No oseltamivir in this case.
Fine, you got.
Wait and watch, and yeah, general treatment.
So you are now going to a round 7, which has a 75 lakh rupees for you. 9 years, known case of asthma, fever, cough, running nose, not very sick, family history of ARI. If you answer correctly, you will get 75 lakh. If you don't, you will get 5,000. What is your take home message? Should we start antiviral and why?
So probably this will go into category B straight away because it is a chronic asthma, most likely. One has mentioned about asthma, it is a chronic lung disease and it is an underlying condition which requires antiviral therapy. And there is a strong history, family history of ARI. So considering all these things in a child who is going to get his asthma worsened very fast, we should start oseltamivir, and there is no harm in using this drug.
Very nicely appreciated. You won the 75 lakh rupees. You are going for the next round. Known case of nephrotic syndrome on steroid, not vaccinated for influenza, pneumococcal, etc. Acute respiratory infection, myalgia, fever, cough, cold. Walk-in patient. Would you start oseltamivir here?
Yes, yes, of course. This definitely requires oseltamivir
Sir, you are
because the
right.
child is,
You are right.
yeah.
You don't want to go into the discussion. You are not taking
Okay.
helpline also. So now it is a 1.5 crore for you. This organizer would give you this check. This is one more 3 years healthy child came with ARI. Symptomatic treatment given, better. Fever reappeared after 5 days. Coughing increased. X-ray bilateral infiltrate and possibility of right upper zone consolidation. Please elaborate this slide.
So this is a quite tricky child because this child was initially a absolutely healthy child and probably developed some ARI initial to begin with, and it seems to have resolved maybe or maybe there was a plateau in the disease, and then the disease has flared up again. So there are two reasons for this. There can be two reasons for this. One is a kind of a prolonged influenza, which we do so see commonly in our patient. So it is a troughs and peak kind of influenza, biphagic kind of a illness per se because of virus, because the virus is traveling from the upper respiratory tract to the lower respiratory tract and itself causing an influenza pneumonia. Second possibility in this child would be a secondary bacterial infection. If like the child has been doing fine and suddenly there is a decompensation sort of a thing, then secondary bacterial pneumonia is a possibility. In this child, probably this is falling into category C. So I would test also and I would start antiviral plus antibiotics also in this case.
Dr. Ravi, before I declare 1.5 crore for you, one question at fifth or
Yes.
sixth day of illness, how much efficient or efficacy of oseltamivir?
So yes, this is a very pertinent question. So oseltamivir is most effective when it is started within 48 hours of initiation of the symptom. Uh, there has been a lot of studies. I went through a lot of literature during like in the past 1 month when we had got such kind of a cases. So they say that wherever is the course of disease, there is no harm in starting oseltamivir because it is not going to compromise anything. It might, might not give that benefit which it would have given if it would have been started in 48 hours. So even like we should not give away the benefit of doubt in such cases. Probably that okay, 4 days has passed, oseltamivir is not going to work, so we should not use it. Rather, I think don't expect too much, but you start with oseltamivir. plus try to correct if there is any other complication as we discussed. So try to treat complication as well as start oseltamivir, though it will benefit a little less than what we expected in early phase of the disease.
Thank you, Dr. Ravi. Dr. Prashant sir, Dr. Ravi has won 3 crore rupees. This was a right answer. Sahi jawab. Sahi answer diya hai sir ne. So 3 crore rupees are in your pocket, Dr. Ravi.
We reaches by
Right.
3 crore.
Doctor, right upper zone consolidation could be due to influenza, which may be an immunological phenomena, or could be secondary bacterial. You can go for a routine CBC, CRP, procalcitonin, and if possible, bronchoalveolar lavage to find out the secondary etiology also. But there is no harm in giving oseltamivir even at 5th day in category C and complicated patient. Dr. Ravi, 9 years fever, myalgia, mild cough, on day 3 difficulty in walking, cough tenderness, and which you described like high CPK. So this child has a classical viral myositis. Any role of antiviral in this situation?
No, the most important role is of hydration. So antiviral are not required in this case. Probably he will resolve on its own.
सर आप कोई पेपर फोड़ के आए हैं क्या? सही आंसर सब दे रहे हैं. 3 to 6 करोड़ हो गया आपका. सही
आज
जवाब.
10 crore जीतना है ना सर.
Okay, chalo. So there is no role of antiviral here. It is a cough tenderness. It may not be a viral invasion, but it could be an immunological phenomena. And this is
Yes.
not the serious condition. So here you can avoid using oseltamivir. So just a few summary about oseltamivir. Potent and selective inhibitor of the neuroaminidase enzyme of the influenza virus A and B. It is a prodrug which is converted to the active form oseltamivir carboxylate in the liver. It inhibits influenza virus replication pathogenicity. It prevents further spread of the infection. It is effective against A and B, both type of influenza. This slide shows how it works, but it's basically a micro and patho. We don't know how it works, but this is the slide showing how does it works. And these are the some guidelines. It was the first oral neuroaminidase inhibitor. It is approved in more than 100 countries. The dosage, Dr. Ravi, would you like to highlight on this slide? Dosage?
Yeah, sure. So there is a uniform dosing in adult. It is 75 milligram capsule, which is available with brand name of Fluvir with hetero company. It can be given twice a day. The general duration of treatment is around 5 days, but yes, of course, it can be increased according to the need sometime. And in children, the doses are weight dependent. So if the child is less than 15 kg, it is 60 milligram uh, per day. That is 30 milligram, 60 milligram in two divided doses. That is 2.5 ml of syrup. That syrup contains 12 milligram per ml. So it is 2.5 milligram. Then it is easy to remember in that way. If the child is 15 kg, 15, then slab of 23, then 40 and more than 40. So 2.5, 3.75, 5 and 6.25 ml. And milligram wise, uh, 60, 90, 120 and 150. So more than 50, it is adult dosing. And in younger kids, the dose is weight dependent. Even in preterm, it can be used. It is the dose is 1 to 3 milligram per kg per day, twice daily. And probably it will come to around 0.25 ml per kg. So it is a good idea to make a chart and keep in handy at your desk so that you don't falter during the therapy. Even with whatever we know, we write day in, day out. Sometimes we do make mistakes. So I always keep a chart with my side desk.
Very nice, Dr. Ravi.
Copy
Very
it.
nicely elaborated. And the post-exposure prophylaxis is 10 days. And during the community outbreak, it can be up to 6 weeks, which can be taken in immunocompromised patient. So the treatment with oseltamivir should be initiated within 48 hours of onset of the symptoms. Will be it is a wonderful drug for walk-in pneumonia, early onset fever symptoms, and resolution is very fast. I'll just share my case history. 3 days back only, I had a 5-year-old female. Patient had complaint of high-grade fever 103, sore throat and severe coughing, myalgia, body ache, sick-looking child from day one. She has a breathlessness, vomiting, or this is a real case scenario. On 23rd, we have admitted this child of this month only. Her body was flushed and child had respiratory finding with distress. Child was admitted on Thursday. CBC, CRP were normal, so it was against the diagnosis of bacterial. Dengue also we had done, which was PCR, and chikungunya PCR was negative. Started on supportive treatment and oseltamivir. This was the X-ray. We can very well see interstitial pneumonia-like picture. Bronchosvascular markings are very prominent. On starting oseltamivir, patient responded very well, and yesterday we discharged on 27th. Coughing has reduced significantly, asymptomatic, fever almost not there for 24 hours. Child has become playful. So this is a practical experience of treating respiratory disease with category B and C with oseltamivir empirically. We could have tried the PCR test, but the cost is bit prohibitive. So in this case, we had a very good response. So antibiotic usage would be reduced with this understanding of the disease, and hospitalization can be avoided. For a high risk category, we should start oseltamivir as early as possible, and this will prevent a lot of expenses of the patient. There are various studies. This is a slide showing how the administration of the drug has helped them and the duration of the disease. This slide also shows that when you had a possibility of severe pneumonia or probability of any severity of pneumonia, empirical use or early initiation of oseltamivir will reduce the chances of complication. Again, this slide showing that early administration would have early discharge of the patient. So guidelines recommendation from WHO also that empirical treatment is strongly recommended, should be started as early as possible. If possible, do lab confirmation. Negative lab test does not rule out the diagnosis of influenza. So empirical therapy is justified. The fear of drug resistance is there. We don't say no to that, but the benefit is more advanced than the risk of getting resistance. So in high risk category also, you should start as early as possible. Even Ministry of Health and Family Welfare of India has recommended that it should be started early, looking to the epidemic and endemicity of the influenza disease. So in summary, this has been recommended for majority of the patient. Proper diagnosis, early treatment, empirical use, and the recommendation by WHO, American Thoracic Society, and Indian Medical Department, they do recommend use of oseltamivir. Thank you so much, Dr. Ravi. You got a very good credit. Can I have some corrupted, मतलब क्या बोलते हैं कि थोड़ा भाग मेरा कर देना out of 1.5 crore, 20% would be my share.
50-50, sir.
50-50. Thank you, Dr. Ravi. Thank you, Dr. Prashant. We stop our presentation here.
Thank you, Dr. Ketan. Thank you, Dr.
Dr.
Ravi.
Ketan, nobody can beat you in presentation.
No.
Your voice is so sweet that whatever the scientific content, it is always a pleasure listening to you.
Thank you, Ravi. Thank you so much. You are also a genius, dear. And I'm so happy that you are with me. It is my privilege that I can have an interaction.
Mine.
And thank you, Hetero team, for making two of us together. Okay.
Yes, thank you.
Over
Thank
to you,
you.
Dr.
Thank you for your insights on Fluhir, and thanks for use of oseltamivir as described in case studies. One important thing is that it should be used in prophylaxis as soon as possible, because that will prevent all the complications and possible admissions or maybe superadded bacterial infections, adding to further cost of the therapy, which is very important. Moreover, the illness can also be serious. So thanks both Dr. Ketan and Dr. Ravi for your wonderful insights. Thank you all the participating doctors who took time from their busy schedule and attended this. Thank you marketing team Hetero for conceptualizing this program. Thanks field people Hetero for making it possible. Thank you IT team Hetero for your super help, and all support. Thanks all of you, and we'll log off. Thank you.
Okay, thank you. Bye-bye.
Right.
Sir, I would like to add, really thank you. It was very interesting session.